Welcome back to World of Pharmacology. Today we are going to discuss on the topic drugs for emesis, reflex and digestive disorders. So what is emesis? Emesis is the process of vomiting. Why this vomiting occurs? It occurs due to stimulation of the emetic center or vomiting center in the medulla oblongata. And this vomiting center receives emetic signals from areas like higher centers in the brain, from the chemoreceptor trigger zone, from vestibular apparatus, from peripheral structures, including the GI tract and nucleus tractus solitarius. This CTS as well as NDS consist of receptors like histamine, dopamine, cholinergic, serotonin, and opioid receptors. Through these emetic signals are passed on. Now, let us see the mechanism of vomiting and the receptors involved. The factors that trigger vomiting are unpleasant sensory stimuli, motion sickness and ototoxic drugs, drugs or chemical radiation, and endogenous toxins, gastritis, biliary, and ureteric colic. They act through different ways to evoke vomiting. First one is unpleasant sensory stimuli. They directly reaches the higher centers and the signal reaches vomiting center and evoke vomiting. In gastritis, biliary, and ureteric colic, they reaches nucleus tractus, solitarius, and the receptors involved are 5-HT3 and NK1. From there, the signal is transferred to vomiting center. Motion sickness and ototoxic drug reaches the vestibular apparatus in internal ear. From there, the signal reaches cerebellum, and the receptors involved there are histamine and cholinergic receptors. From there, the signal is transferred to CTC, that is chemoreceptor trigger zone. There, the receptors involved are 5-HT3 and NK1, and from CTS, the signal is transferred to vomiting center. And drugs or chemical radiation and endogenous toxins reaches the chemoreceptor trigger zone, and the receptors involved are 5-HT3 and NK1, and the signal is passed on to vomiting center, and thereby vomiting is evoked. Antiemetics are the drugs that are used to prevent or suppress vomiting. They are classified as Anticholinergics, which include hyoscine and dicyclomine, H1 antihistamines, and the drugs under that class is promethazine, diphenhydramine, dimenhydrinate, doxylamine, cyclizine, meclizine, and cinnarizine. The third class is neuroleptics, which include chlorpromazine, prochlorperazine, and haloperidol. Prokinetic drugs, which include metoclopramide, domperidone, cisapride, and nusaprid. 5-HT3 antagonists, which include ondansetron and granisetron. Now let us see in detail how these classes of drugs suppress vomiting. First one is anticholinergics, and this class of drugs include hyoscine and dicyclomine. This hyoscine acts by blocking nerve impulse conduction across a cholinergic link in the pathway leading from vestibular apparatus to the vomiting center, and therefore it is not effective in vomiting of other etiologies or other causes. So it is considered most effective drug for motion sickness. Next class of drug is H1 antihistamines, and the drugs coming under it are promethazine, diphenhydramine, dimenhydrinate, cyclizine, meclizine, cinnarizine. So this promethazine, diphenhydramine, and dimenhydrinate, they give protection from motion sickness for 4 to 6 hours, but the adverse reaction associated with these drugs are sedation and dryness of mouth.
Cyclizine and meclizine are less sedative and less anticholinergic. And this meclizine is really long-acting and is used for seasickness as it gives protection for nearly 24 hours. Next is sinanazine. It is an antibiotic drug, and they act by inhibiting the influx of calcium ions from endolymph into the vestibular sensory cells that mediates labyrinthine reflexes.
Anticholinergics, antihistamine class of drugs, are the first choice of drugs for motion sickness. Drugs that are used for the treatment of motion sickness should be taken half to 1 hour before commencing the journey for better result. And it is better to avoid antihistamines for morning sickness. If an antiemetic has to be used, drugs like dicyclomine, promethazine, prochlorperazine, or metoclopramide may be prescribed. Next class of drug is neuroleptics. They also act as potent antiemetics as they block D2 receptors in the chemoreceptor trigger zone. They have broad spectrum antiemetic action as they are effective in drug-induced and post-anesthetic nausea and vomiting, disease-induced vomiting, in gastroenteritis, uremia, liver disease, migraine, etc. For treating vomiting due to radiation, it is used in malignancy-associated and cancer chemotherapy-induced vomiting. It is generally not used to treat morning sickness, but it is used in the treatment of hyperemesis gravidarum, that is a severe type of nausea and vomiting during pregnancy. Example for a neuroleptic is prochlorperazine. We know that the neuroleptics are also used as antipsychotic drugs. So the antiemetic dose is generally much lower than the antipsychotic doses. These agents should not be administered without establishing the cause of vomiting, as they may mask the underlying disease and delay the diagnosis. And one of the adverse effects is acute muscle dystonia may occur after single dose. Prokinetic drugs are the ones that promote gastrointestinal transit and speed gastric emptying by enhancing coordinated propulsive motility. Acetylcholine is the major neurotransmitter in the GIT that is responsible for the peristaltic movement. 5-HT4 receptor increases the release of acetylcholine, whereas D2 neurons, dopaminergic D2 neurons, and 5-HT3 receptor has an inhibitory action on acetylcholine. So these prokinetic drugs act by the 5-HT4 agonistic activity and D2 and 5-HT3 antagonistic activity. Now let us see the prokinetic drug metoclopramide. This metoclopramide is chemically related to procainamide, but there is no pharmacological similarity. It acts predominantly as a dopamine antagonist and also has 5-HT4 agonist properties. Mechanism of action is through both dopaminergic D2 and 5-HT receptors, and it acts on both GIT, that is gastrointestinal tract, as well as on CNS. Let us see its D2 antagonism. It inhibits the vomiting due to the blocking of D2 on chemoreceptor trigger zone. And 5-HT4 agonism, metoclopramide acts on 5-HT4 and enhances the release of acetylcholine that causes increased lower esophageal sphincter and gastric tone, thereby accelerating gastric emptying and transit through the gut. Now let's see its adverse reaction. Generally, this metoclopramide is well tolerated and considered relatively safe, but the adverse effects associated with it are sedation, dizziness, loose stools, muscle dystonia, especially in children, and long-term use can cause Parkinsonism, galactorrhea, and gynecomastia. This metoclopramide stimulates the secretion of prolactin, but it should not be used to augment lactation. Now let us see the uses of metoclopramide. Metoclopramide is used as an antiemetic for many types of vomiting like postoperative, drug-induced, disease-associated, especially migraine, radiation sickness, etc. But they are less effective in motion sickness. They are used to accelerate gastric emptying when emergency general anesthesia has to be given for emergency surgery. They help to assist the passage of tubes, including an endoscope, into the duodenum. It is used to treat dyspepsia and other functional GI disorders. Metoclopramide also succeeds in stopping persistent hiccups. Other drugs under Prokinetic drugs are domperidone and cisaprine. Next class of drug is 5-HT3 antagonist. The drugs are ondansetron and granisetron. Ondansetron is the prototype of a new class of anti-emetic drug that is developed to control cancer chemotherapy or radiotherapy-induced vomiting. It is highly effective in post-operative nausea and vomiting as well. Next, let us see the mechanism of action. It blocks the depolarizing action of 5-HT through the 5-HT3 receptors present on vagal efferents in the gastrointestinal tract as well as in NTS and CDC. This action reduces the communication to the vomiting center in the brain and thereby decreases the nausea and vomiting the patient experiences. The adverse effects associated with 5-HT3 antagonist or ondansetron are headache, which is the only common side effect, mild constipation or diarrhea, and abdominal discomfort occur in few patients. Rashes and allergic reactions are reported, especially after IV injection. Generally, this ondansetron is well tolerated, and these are the adverse effects that are seen. Next drug is granisetron. It is 10 to 15 times more potent than ondansetron. Its plasma T-half is longer, and it needs to be given only twice on the day of chemotherapy. And the side effect profile is similar to that of ondansetron. Now let's study about GERD, that is Gastroesophageal Reflux Disease. It's a condition in which acid in the stomach reaches into the esophagus and causes mucosal inflammation. Severity of GERD may be graded as stage 1. In stage 1, there will be occasional heartburn, which is less than 3 episodes per week, mostly in relation to a precipitating factor. The symptoms will be mild and there will not be any esophageal lesions. In stage 2, greater than or equal to 3 episodes per week of moderately severe symptoms. Nocturnal awakening due to regurgitation. Esophagitis present or absent. In stage 3, daily or chronic symptoms. Sleep disturbed, esophagitis, erosions, stricture, and the symptoms recur soon after the treatment is stopped. Though GERD is primarily a GI motility disorder, acidity of gastric contents is the most important aggressive factor in causing symptoms and esophageal lesions. Treatment of GERD is individualized according to severity and stage of the disorder. The two strategies for management of GERD are decrease acid production and increase forward movement of GIT. The drugs used are proton pump inhibitors. They are the most effective drug as they give both symptomatic relief as well as healing of esophageal lesions. Only proton pump inhibitors can achieve acid suppression level of pH greater than 4, that can be maintained for approximately 18 hours per day, which is considered optimal for healing of esophagitis. Therefore, Proton pump inhibitors are the drug of choice for all stages of gastroesophageal reflux disease patients, particularly stage 2 and 3 cases. These proton pump inhibitors have no effect on LES2. The next drug of choice is H2 blockers. These H2 blockers reduce acidity of gastric content, and they too have no effect on LES2. H2 antagonists are indicated in stage 1 cases or as alternative to PPIs or proton pump inhibitors in stage 2 or 3. The daily dose is divided into 2 or 3 portions for better response. The third class of drugs is antacids. They are used for the relief of occasional or intercurrent relief of heartburn in GERD. Sodium alginate forms a thick frothy layer which floats on the gastric contents like a raft and thus prevent the contact of acid with esophageal mucosa. It has no effect on LES2. The next drug is Prokinetic drug. This drug is used for increasing GI motility. They relieve regurgitation and heartburn by increasing LES2, improving esophageal clearance and facilitating gastric emptying, but do not affect gastric acidity or promote the healing of esophagitis. Next one is carminatives. Drugs which promote the expulsion of gas from GIT is known as carminatives. Examples are sodium bicarbonate, cardamom tincture, spices. They are used for flatulent dyspepsia. Next class is digestin. They are substances that promote the digestion of food: papain, pepsin, and diastates. So these 7 classes of drugs are used in the treatment of GERD. Thank you for watching. See you on the next video.